Okay, well then, Dr. Meyerhoff, you are up.
Perfect. Hi, everyone. Let me share my poster and I'll walk folks through it. Um, so this is a presentation of some work that we conducted as part of two different projects. The first is a randomized controlled trial of a particular intervention called Small Steps SMS, which consists of interactive automated text messages delivered to young adults in particular with affective disorders. So we delivered this same intervention through a consented randomized control trial. And then we also actually, in parallel, deployed this on a public website as an open label kind of trial. Basically, anybody could sign up. There wasn't an age restriction. There was no consent form. It was done under a waiver of consent. And while this wasn't the primary purpose of the study, what we've been able to do is actually look at the data to try to understand the difference between how people engage in digital mental health interventions in consented research trials and how the general public may use these things in real world use. And what we found is really striking differences. So just for some context, we deployed this to 80 young adult participants who were in a consented research trial and also over 5,000 US-based adult visitors to Mental Health America's website. And the age differences are pretty different. So the public deployment sample was older and also was had more psychological distress. And what we found was that folks in the randomized controlled trial both engaged longer and more frequently, substantially more frequently than folks in the public deployment. And we can see that the days engaged, this was a 56-day study. So folks in the public deployment engaged for about 40 days, folks in the RCT engaged for 50 days. And what we found is the number of responses that we got to these automated text messages were way, way higher in the RCT than in the public deployment. So you can see 73 responses on average versus almost 16. And more than that, we see that the length of these responses were quite a bit longer in the RCT than in the public deployment. And the point here is that the way we design digital mental health interventions for consented research trials may not translate as readily to broader populations that we're actually intending to reach in the long run. So what this suggests is that we need to really deploy implementation ready tools that are designed with the broader public in mind, and that consented research trials may actually present a little bit of a barrier and a challenge for us to actually get to that point. So with that, I will, if there's any time for questions, or we can save it for the end.
No, let's do questions right now. Perfect. Thank you so much for that. And as a implementation scientist, thank you for your results, because that will make sure that I still have a job tomorrow. So yay. Tyler put a question in the chat. Do you want to read it, Tyler, or do you want me to read it? What will be best?
Sure, I can read it. My question was, do you think there was more engagement from the randomized control trial folks because there was more buy-in? I was thinking maybe because they know they're participating in a study, they might feel more responsibility or attachment to completing the intervention as opposed to the real world deployment where they aren't as bought in, potentially.
Totally. I think that's one of the potential explanations here. I think there's probably a bunch of different features, but people who are just randomly stumbling upon something on the internet may say, oh, this looks interesting, let me try it, without the rigmarole, for lack of a better term, that goes into actually like reading a consent form, going through eligibility screening. There's a lot of different steps involved in consented research, whereas picking an app off a random website that you're on is just way less effort. And so there may be like a cognitive dissonance piece here, or there's an effort investment.
Thank you. Trina asked also a question. Trina, do you want to ask it, or do you want me to ask it?
Yeah, let me sorry, let me come on camera.
Oh, I see the question. I
Yeah,
can.
just curious about if it was, if they were incentivized in any way to participate, that usually changes engagement. But I actually believe the previous speaker's very valid point that, they're participating in something that, has a scientific soundness halo effect. But curious about any of the incentives, because that might also impact.
Yeah, great question. Thanks for it. So participants in the RCT were incentivized to complete study assessments, not to engage in the intervention itself. So we did periodically compensate people for completing the surveys, the PHQ, the K10, at 0, 4, and 8 weeks, but not for actually engaging in the intervention itself using the text messages.
Okay, well, thank you so much. Margaret, I see your question, so I'm going to direct Dr. Meyerhoff to your question in the chat while I ask Shilpa Hampole to share your poster. Thank you so much.
Yeah, let me stop sharing. I do think age differences probably also play a little bit of a role. The older age group and the broader and more heterogeneous mixture of the folks who use the public deployment version of the tool probably did also contribute to engagement. We know people with different demographics use these programs a little differently, but the differences are so striking that I don't think that's the only thing happening here.
Okay. Shilpa, the virtual floor is yours.
Awesome, thank you. Hi, everyone. I am a researcher at the National Center for PTSD, and our team conducts research and development on mental health apps for military veterans. And one area of focus is user engagement, of course. Overall, there is very little literature that suggests that mental health symptom severity is a predictor of engagement with digital health technologies. So for this study, we were interested in exploring how trauma symptoms specifically relate to engagement with a trauma-focused app.
Sorry, Shilpa, to interrupt you. If you're sharing something, we're not seeing it.
Oh, okay. I am sharing. Let me see. Are you able to see my?
Yeah, there we go. Yep.
Okay, sorry about that, everyone. One moment, let me enlarge this. Okay, still working?
Yes.
Okay, so let me. I'm sorry, I lost I'm gonna try this again. Okay, sorry about that. So again, for this study, we were interested in exploring how trauma symptoms relate to engagement with a trauma-focused app. And we processed and analyzed anonymous usage data from over 27,000 users of an app for military sexual trauma known as Beyond MST. This app is free, publicly available in the App Store. Anyone can download it. It contains resources, psychoeducation, evidence-based coping tools, and we use scores from 3 in-app assessments as the symptom-related predictors. This is shown on the left side of this figure in the center, including the PCL5, and 6 different measures of engagement as outcome variables. And we employed a few different modeling techniques since the outcome variables varied in type and distribution. And we found that more severe trauma-related symptoms predicted statistically significant decreases in duration of app use and frequency of feature access related outcome variables. However, a caveat here is the effect sizes were very small, which does limit the clinical meaningfulness of these results. But overall, there might be a signal there in that symptom severity is something to consider as a possible predictor that could be explored further in a controlled trial, although Dr. Meyerhoff just told us, showed us how engagement can vary in different study settings. But it is something that we might want to consider in the future that might drive app design decisions, implementation decisions. So definitely need more research in this area.
Okay, thank you so much. We have time for 1 or 2 questions. And you can unmute, raise your hand, put it in the chat, whatever seems the easiest. Okay, sounds like everyone is very deep in thought. So if you have any questions for Shilpa, please put them in the chat. In the meantime, we're going to ask Jack. Jack, I'm going to mispronounce your name, so I'm very sorry about that in advance. Svoboda? Nope, that is not how to say your last name.
It's all right, I forgive you. It's Svoboda.
Thank you. You're up next.
Sure. My screen coming through okay?
We can say it now.
Great. All right, so hi everybody. I'm Jack. This is a work in progress where I'm looking at the very same data that Dr. Meyerhoff presented about, specifically the public deployment of Small Steps SMS, which, as he said, is a rule-based automated text messaging intervention for the promotion of mental health self-management. Here I'm looking at just the public deployment, not the RCT data. And I wanted to zero in on the unsolicited interactions with this program. So over the course of the program, we received 70,000 solicited messages. That is people responding to prompts that the system asked them, like, how are you feeling right now? Or did you get a chance to practice this tool or strategy or whatever, right? But we also received 11,000 unsolicited messages, which were not in response to any questions. And so we had 3 coders perform a content analysis of these unsolicited messages, a random sample of these unsolicited messages. And we developed this code book displayed on the table in the middle. And what we found was that more than half of them were these kind of top 3 conversational type of messages, mostly just polite responses, things that are kind of like perfunctory, conversational, common ways of speaking to people, right? Even though the system is not a person, a lot of people would respond when it said hello with like a polite hello or thanks or things like that. And we're hoping to use this information from the unsolicited messages to clarify unanticipated uses or highlight any potentially unmet needs that people who use this program have. And I think that the frequency of these conversational messages might indicate that people want a little bit more of that small interaction, right? That's not necessarily about the content of the self-management of mental health, but just kind of polite little interactions that you might have with people that you pass on the street or something like that. Additionally, 15% of the messages were mistimed responses. And those excite me because they present an opportunity to improve the way the system is handling those interactions with people, which is maybe too in the weeds for this, but a lot of the time it's just we could adjust the window where people could respond to messages. We could fix bugs in our system that would allow them to get more out of the interaction that they're having. And in the future, we're hoping to use our human-coded sample to fine-tune a language model for the coding of the rest of the unsolicited messages. And we'll also be looking more closely at some of the metadata and how it compares to these different kinds of messages from the system.
Okay. Sounds great. Thank you. Any questions for Jack? Comments, thoughts?
Okay, if I jump in?
Yes, please.
Thanks. This was really interesting, Jack. I was looking at the provocative message coding that came in. Like I know it was a small sample or small percentage, but was wondering if that was broken down anymore, if there were any people who were, I don't know, maybe mocking the automated messages or being like just dismissive about the service in general, if that was broken down in any kind of like subject matters in itself.
Yeah, we certainly could break that into some distinct codes, but like you said, it's pretty small right now. There were some different kinds of provocative messages. I think a lot of them were, how do you say, like kind of almost cries for help, like, talking about how useless this information is, like this isn't going to work for me, Um, and also within that code, there's a lot of frustration that's expressed, just like this doesn't work how I expected it to, or this this particular feature isn't helpful and you should cut it and I hate it, stuff like that. Sorry, does that answer your question?
It totally does, and I think that's just an interesting thing to kind of unpack there. I don't know if you're getting similar things with the feedback, the commands as well. But I don't know. I just feel like sometimes that can be maybe a blocker for some people engaging with automated services in general. They just don't feel like it's doing anything, and if they either disengage or they'll express some sort of frustration, and if they're expressing the frustration, that could be something to mind.
Absolutely. Thank you.
We have time for one more question or thought for Jack before we go to the next presenter. Yes.
Just a short question. Thanks, Jack, for the presentation. So out of these 5,000 individuals who took part, how many percent of those sent some of these messages? Because you said it's 14% out of the total messages, but how many people?
Yes. Oh gosh. I don't remember exactly. There is like a very small percentage of those people sent a very large percentage of the unsolicited messages. I don't remember the exact figures, but
But that makes sense, I think.
Yeah.
Thanks.
Okay, thank you. And for the 3 presenters that already went, if you feel comfortable, please add your email to the chat so that audience members can reach out to you after if you would like to. If you want to remain anonymous, then you don't have to. Next, we have Dr. Sarah Senti.
Thank you. Hi, everyone. Similar to Shilpa, I work with the National Center for PTSD. I run the user experience program there. And today I'll be discussing the UX research that we've been conducting on PTSD Coach. So PTSD Coach is highly rated, effective. It's a free resource. It provides coping tools, symptom tracking, psychoeducation, and resources for PTSD. However, like many digital mental health interventions, success is tempered by low user engagement, which does indicate a need for UX research. So in the last couple of years, in the first step in addressing this, we conducted a series of 21 in-depth interviews with both new users and then veterans experienced with the app to get their feedback. And then we did also have some follow-up 3 months later with the initial new users. And then in addition, we knew that the UI needed an improvement. So we conducted 2 rounds of surveys with over 200 PTSD Coach users who are also veterans to see their preferences for different design options. We found that users liked the app's privacy, that it's anonymous. They come back for the coping tools and find them really helpful, but they did express a strong desire for more guidance and personalization. And then they did mention that the user interface felt a little bit sterile. So our design preference surveys showed that users, when given an option between illustrations, or calming nature-based images, they heavily preferred the nature-based images. The next round showed that they liked bold contrast buttons. They found that they were easier to read, felt grounding and very compelling. So based on this feedback, we've implemented several user-centered improvements. We included personalized home screen recommendations based on why they said they're coming into the app. We have these relaxing nature-based visuals that move on the home screen. We've added 9 new tools. We've improved the existing ones based on feedback. We added 7 new progress tracking options, including medication and trigger tracking based on suggestions. We've enhanced the reminders, expanded the Learn section to include information on relationships, which was also suggested. And then we implemented some anonymous social features, so it stays private, but can add that community component that they were asking for. The app is expected to release later this summer, and we're really excited to get feedback to evaluate the impact on user satisfaction and engagement, both through anonymous usage data and then also further qualitative research. So thank you so much.
Thank you. Any questions for Dr. Senti? Just as a clarification, the PTSD coach is the one that users can use on their own. Like, this is not the supplement to a work being done with a therapist. Is that right?
It can be used both ways. And some of the research has been conducted on how it sort of improves treatment when it's been used as a companion too, but it is designed to be a standalone. It is not one of our apps that's sort of like CPT coach or PE coach, where it's really designed to be used with a therapist. So
okay,
standalone, but some providers do use it as a supplement to treatment.
That's great.
Yeah.
Okay, so if you have any questions for Dr. Senti, please put them in the chat. In the meantime, we are going to ask Dr. Elmer to get ready for his presentation.
Hi there. Yeah, I'm Timon. I'm a psychologist and postdoc at the University of Zurich. That's in Switzerland. I'm happy to be here virtually today. So we designed a just-in-time adaptive intervention with the aim to help people with depressive symptoms to activate their social support resources in critical moments in their daily lives. And so JITIs are interventions in people's daily lives, ideally when and where they need it most. And don't you look at the poster yet in too much detail, because I'm going to zoom in on the relevant factors in a bit. Apologies for the long format at this point. So we tested the feasibility of this social support just-in-time adaptive intervention in a population of 25 people who were looking for psychotherapy in Switzerland and had at least minimal levels of depressive symptoms. So while doing this, we addressed an important question in the field of JITIs, which is when actually is just-in-time? Because to date, we have no empirical standards or basis to know when people need an intervention in their daily life. And this is what this poster is about. And so, like usual in such interventions, we used experience sampling methods or ecological momentary assessment data, where we asked people 6 times per day on their smartphone how they're feeling, etc. In this case, we asked them specifically about loneliness. Here you can see the trajectories of one individual over 21 days. And so, based on these data, how can we trigger an intervention? Well, one strategy, and that's the simplest strategy, is to say, oh, if people score above a 5 on a 7-point scale, then this is a point in people's lives when they feel lonely and they need some support. But this is not personalized, and it might be better to take people's own baseline values and fluctuations into account. And so this is what the orange line here shows, which is a so-called statistical process control technique. And then I thought, why would emotion dynamics tell us something about when people need an intervention in daily life? Why not ask people whether they need an intervention or whether they need social support? And this is the third condition that we applied in this micro-randomized trial. And micro-randomized trial in this context means that each person at each EMA time point randomly gets allocated to one of these 3 conditions. So we can compare people within person and not between person, like in an RCT. What were we interested in here in the results section? So we compared these three ways of triggering the intervention by how people rated the intervention at the next measurement time point, which was 2 hours later. And here you can see the rating of how well they perceived the timing of the intervention to be. And you can see that the support need condition, so when we asked them directly whether they need support, was outperforming the other two conditions, but also that this condition was rarely triggered. So we had very few instances of people actually indicating that they need support, which might have to do with the depressive symptom conditions. Also, when we look at the helpfulness of the intervention and whether people actually adopted the behavior, namely seeking social support, and we see that the support need condition outperformed the other two conditions. So what do we learn from this? It's really difficult to time interventions for individuals with depressive symptoms if you want to do a just-in-time adaptive intervention study. But the support need or directly asking people whether they need support outperforms current approaches that are relying on emotion dynamics or fixed cutoff scores. Thank you for your attention.
Thank you.
Now I'm going to zoom out so you can see the bigger picture.
Okay. Any questions for Dr. Elmer? You can put them in the chat, raise your hand, or just unmute. I think we have a question from in the chat. Could you please clarify how the SPC condition worked?
Yeah, thanks for the question, Ami. So SPC basically calculates in a baseline period, in our case, 7 days, per person, the mean and the standard deviation of their values for a given variable. And then in simple terms, you just define that a new value is surprisingly high if it exceeds the person's mean level plus 2 standard deviations. And this is the line that you see here. I hope this clarified the SPC condition. I know it's a very short time period to explain such complex things. Thanks.
Okay, we have time for one more question, if anyone has one. Okay. Lauren wrote, what were the response rates for support need, i.e., how often did users answer the question? Did you see strong compliance with the question?
So the response rates, so overall for all ESM questions or EMA questions was about 80%, with 6 EMAs per day. So every time they could answer these questions, for every round. But rarely people indicated that they needed social support. I don't know the percentage, but it's much rarer than people indicating distress, for example, high levels of loneliness.
Okay. Well, thank you so much. I'm going to ask the two speakers who just went to put your email in the chat if you feel comfortable. And then I'm going to ask Dr. Dauber to get ready for your presentation.
Thank you. Hi, I'm just going to share my screen. Sorry, my computer's being a little bit slow. Can you all see that?
Yes, we can.
Great. Hi, everyone. My name is Sarah Dauber, and I'm a researcher at Partnership to End Addiction in New York City. And this is a study that we did to inform the development of a text messaging intervention to support postpartum mothers in recovery from alcohol use. So we know from research that the early postpartum period is a high-risk time for mothers with histories of at-risk alcohol use. And while many people actually do reduce or completely stop drinking during pregnancy, the stresses associated with parenting a newborn can often lead mothers to resume drinking in the early postpartum period, and stigma and fear often prevent people from accessing needed support during this time. So text messaging interventions have a lot of potential to provide ongoing recovery support for alcohol use during the postpartum period, and are likely to have increased acceptability to this particular population due to their potential for anonymity and convenience. So the study presented in this poster is part of a larger research program that aims to develop an adaptive text messaging intervention to support postpartum alcohol use, or to support reduction and continuing recovery from postpartum alcohol use. So we conducted a micro-randomized trial to compare different types of intervention messages on their acceptability and impact on reducing risk factors for alcohol use during the postpartum period. And we were also interested in assessing general feasibility and acceptability of the MRT design, because this was, we didn't find any other studies using that design with this particular population. So to develop the intervention messages, we relied on a conceptual model of postpartum alcohol use, which you can see down here on the poster. And this model specified 3 primary intervention targets, which are motivation to avoid drinking, self-efficacy, which included both drinking self-efficacy and maternal self-efficacy, and self-regulation or use of adaptive coping strategies. So for each of these targets, we developed 2 different types of intervention messages. Drinking focused messages were those that were directly focused on reducing alcohol use, and then maternal focused messages were sort of more broadly focused on the transition to motherhood and kind of maternal identity and things like that, and not directly focusing on alcohol use. So we had a sample of 65 postpartum mothers who participated in a 28-day micro-randomized trial. And we sent ecological momentary assessment surveys 4 times each day, 1 morning survey, 2 hourly surveys, which were sent randomly throughout the day, and then 1 optional nighttime survey. And after completing each of the hourly and night surveys, participants were randomized to either receive a maternal focus message, a drinking focus message, or no message at all. And then 15 minutes later, they would get another EMA survey to collect the outcome data. In terms of what we found, generally, we found that feasibility and acceptability of the MRT design was supported in this population. We had survey completion rates ranging from 79 to 93%, which is in line with other studies using EMA with this population. And participants also reported relatively low burden associated with study participation. In terms of message acceptability, the maternal messages were preferred overall by participants. They were rated as more helpful and more likely to evoke positive feelings compared to drinking messages. And these findings likely reflect the central role of maternal identity during the postpartum period. In terms of the impact of intervention messages on the target outcomes, the only statistically significant impacts we found were for drinking self-efficacy. So we found that receipt of any intervention message compared to no message was associated with an increase in reported drinking self-efficacy at that 15-minute time point. And this effect was found for both drinking focused and maternal focused messages with no difference between them. But when we did a follow-up analysis, we found that the impact of maternal messages on drinking self-efficacy diminished over time while the effect of drinking messages persisted. So this suggests that while maternal focused messages may be effective initially in terms of engaging mothers in the intervention, there may be a need also for messages more directly focused on drinking to achieve sustained effects on drinking related outcomes such as drinking self-efficacy. And while we didn't find any significant impacts on the other outcomes, the sample was a bit small, so the study wasn't powered for detecting significant effects. We did find trends in the expected direction for all the other outcomes. We definitely did have some limitations with this study, most notably the fact that the sample was small and it was not a fully powered study. Also, most of the sample was not actively drinking during the study period, so that really limited our ability to look at intervention effects on alcohol use specifically. But despite these limitations, this study does represent a first step towards developing the first adaptive text messaging intervention that's tailored for supporting postpartum mothers with histories of at-risk alcohol use. Thank you.
Okay, thank you. Any questions for Dr. Dauber? Okay, in the interest of time, I'm gonna, oh, sorry, go for it.
Can you say a bit more about how you're using this data to sort of develop the intervention?
Sure. So the message data specifically, we have ratings on all of the messages in terms of the different domains that are in this table here on how people perceive them. So we're going to be using that in terms of selecting which messages to include and which messages to maybe drop. But we also, I think mostly what we're going to be using is data that's actually not presented in this poster from the EMA surveys in terms of looking at like the predictors of motivation, self-efficacy, and self-regulation in terms of tailoring the messages more adaptively. That's sort of our next step, is to look at those data. Also, we're looking at things like time of day that the messages were received and whether that makes a difference. And then, you know, our hope is to get funding to do a fully powered micro-randomized trial to and to be able to include some of those adaptive tailoring elements based on what we found.
Okay,
Thank you.
thank you.
Very cool.
Dr. Dauber, you have a few more questions in the chat, but I'm going to ask Emily to get ready to present your poster.
Awesome. I will share my screen. Great. Is that showing up okay?
Yes, it is.
Okay, awesome. All right, so hi everyone. Today I will be talking about the impacts of coaching on engagement with an automated text message-based system for anxiety and depression self-management called Small Steps SMS, which we heard Dr. Meyerhoff and Jack talk about a little bit earlier. So in this randomized control trial, we enrolled 120 non-treatment seeking young adults with depression and anxiety. And participants were randomized to one of three arms of the study, one being a psychoeducation only control, and the other two being small steps with machine learning or small steps without machine learning. And so if a participant did not reply to a small steps message for 3 or more days within the first 2 weeks of the 8-week program, they were then re-randomized to either continue small steps self-guided or to receive human coaching, which would be adherence focused. And so we wanted to look at what engagement metrics looked like for these different populations who engaged early on in the study versus those who disengaged early on. And so kind of looking at these metrics, we found that those who were engaged early on in the study sent many more messages to the program itself than those who disengaged early on in the study within those first 2 weeks. And they also engaged for longer than those who disengaged early in the study. And then kind of narrowing in on those who disengaged within the first 2 weeks and were re-randomized. Those who continued the program self-guided sent more messages to the Small Steps program than those who received human coaching, and they also engaged with the program for longer than those who received human coaching. And so what we found from this is that overall, participants who disengaged early on in the intervention and received human coaching were less engaged overall with the intervention than those who did not receive human coaching, which seemed a little bit counterintuitive in terms of what we've kind of seen in the literature about coaching and hold some implications for what coaching might look like in future iterations or if it should be involved at all. That's all. Thanks so much.
Thank you. Questions, comments for Emily? Were the participants told they were going to be outreached if they disengaged, or was it kind of like a surprise? I'm here.
So I believe they knew that they might be re-randomized to either coaching or the self-guided program. They didn't know which they were going to receive, but then as soon as they were randomized, if they did receive a coach, they would then get a message from them letting them know, like, hey, I'm your coach, and giving them a little bit of insight into what that would look like.
Okay. Any other thoughts, questions? Okay, then thank you, Emily, so much. The chat is blowing up with questions as people kind of still marinate on all the knowledge that they're getting. So please be on the lookout. I'm tagging people based on what I'm guessing is the question is directed to. So if you get tagged, please answer. And we have last but not least, Leah Follett.
Yes,
Thank you
Leah Follett. Honestly, I take any pronunciation of my last name. I don't care. Okay, so this is kind of a pilot-ish study. I am looking to expand it out to community members, but this was basically just like, can I ask these questions? But the goal of this was to really just understand barriers to crisis line usage. So for context, as many people know, suicide is the leading cause of death. And to really combat this, quite a few nonprofits and also just the US government have started funding crisis lines, which is meant to be like last line of defense. If someone is in a crisis, they call in, they text in, and this should help them. But the problem is that a lot of people don't actually engage in these services. And so my goal, and really like my entire research line, is just understanding why they don't. Is there something that we should improve? So what I ended up doing was I recruited people who had a recent history of a suicidal crisis, and just basically asked a lot of questions about like, have they used a crisis line? What are their thoughts about crisis lines? And generally, I found that most participants were open to using crisis lines, but the people who said that they were open to potentially using them in the future typically actually hadn't ever contacted them before. And the 12 people who actually had used the crisis line in the past, 5 reported being open to it again in the future. We also did a fair amount of qualitative coding of just questions about like, what are your associations or thoughts about crisis lines? A lot of people ended up saying that they think crisis lines don't work. And then a fair number of people also said that they could potentially see a crisis line working, but really they would personally prefer to talk to a known individual. So in this, we kind of included friends, family members, psychologists or psychiatrists. And then I also want to point out that one of the things that we looked at was like the methodology that people would be most comfortable with actually engaging with. And despite there actually being a fair amount of concern of using crisis line texting services, because like it's just harder to tell, honestly, what people are saying through text, a lot of people were much more comfortable with the idea of texting, especially to like any sort of in-person crisis. Last thing to point out, really, in terms of like people's just general vibes about crisis lines, most people were really kind of in like the positive to neutral range for people who had never contacted a crisis line. And then generally, if people had contacted a crisis line, it was very split. They were either positive or just negative impressions. Yeah, I'm happy to answer any questions that people have.
Thank you. So let's open it up for questions for Leah. Yes.
Hi, Leah. This is really nice work. I have one question about whether or not you had a sense that disclosure to, I see that people are more comfortable with texting, and so sort of as you go from in-person to kind of more anonymous type interactions, that seems more acceptable to people.
Mm-hmm.
Is there a sense that you have that disclosure to anybody, especially a live person at the crisis line could be one of the barriers that people are facing?
I think just based off of like my general thoughts, I would say yes. From our data, I actually don't know that we saw a lot of that, but I do think it would be an interesting avenue to explore in the future, especially as like I'm planning to open this up to not just undergraduate students at the University of Georgia. Yeah.
Okay. So we have time for another question for Leah, as well as if anyone had any other thoughts for any of our presenters. And I think there was also a question that sounded like it was a more general help in the qualitative research realm, which was wonderful to see that there were so many mixed method research presentations today. I have found, just going with what Leah just said, it's always 50-50 when I ask this kind of question at the end. Either we have like 5,000 like hands up, or we have like radio silent, everyone goes to mute and then turns off their cameras. I'm not sure how to take that information, but I am also very aware that if you're semi-remotely close to the East Coast of the US, that this is right around lunchtime or past lunchtime, depending on when it is that you eat. So I'm not going to take it personally. And I'm happy to also continue the conversation offline, either in the lobby or Leah, please put also your email in the chat if you feel comfortable, as well as Emily. And I wanted to thank our presenters so much for sharing your wonderful work with everybody. And thank you for your audience members for joining and asking very insightful questions so we can continue to learn from each other. So thank you so much. See you all in 10 minutes for the next session. Bye.